Perfect. So for those of you who are joining for the first time, I am Professor Corner, and I do like for students to be active. I do check the chat often. So if you guys have any questions, please feel free to type into the chat, or if you want to unmute and ask a question, that is perfectly fine also. So we're going to be covering a couple of cardiovascular diseases. We'll be taking breaks throughout the webinar, and then of course we will get into our NCLEX questions at the end. Are we able to access recorded? Cecilia, yes, you guys are. So there is a link that says previous webinars. So at some point when all the webinars end, they will be uploaded into that area. So you're able to access all prior recordings. Okay, I'm not sure exactly how soon they are loaded after the webinar concludes, but usually give it like a couple of hours. No problem. So let's get into it. So these are the objectives for tonight's webinar. So we're going to be talking about three particular cardiovascular disorders. We're going to talk about risk factors, signs and symptoms, as well as how they are managed. And it's very important, you guys, when it comes to the NCLEX, that you not only recognize signs and symptoms, but you know treatment. Because when it comes to certain questions, how do you know your treatment is working? You know, how do you know your client's condition is improving? How do you know if your client's condition is getting worse? Okay. So first up, we are covering hypertension. So what exactly is hypertension? So for those of you who don't know, hypertension is typically called the silent killer. Okay. That is because most people, I want to say not even most, majority of individuals that have hypertension, they don't have signs or symptoms. Okay. So your blood pressure could be elevated at this moment and you truly have no idea. Now, usually when people start noticing something might not be right, it is because of the complications that they experience from having elevated blood pressure for so long. So for example, the eyesight starts to suffer. You notice things are a little blurry. You notice you got to strain a little bit. So, you go to the eye doctor and then you start seeing, okay, wait a minute, when do my eyes get so bad? Can I make the slide bigger? I'm in slideshow view. I'm not sure. Let me see. Can I make the slide? Give me 1 second, you guys. What I'm going to do is let me disconnect from, I'm on my other monitor. So normally with that, sometimes the screen looks a little small. So let me stop sharing and I'm going to share again. Give me 1 second. Maybe this will work. Hopefully this will work. How's that? That view, is that better for you guys into the chat?
Yes.
Perfect. Thank you. I'm on my double monitor. So sometimes I don't know how it looks when I share it. Perfect. So back into it. What exactly is hypertension? So again, some people do not have manifestations right away. Usually if the eyesight starts going bad or the kidneys become affected, okay, that's when people start noticing something might not be quite right cardiovascular wise, or you're just doing a routine checkup. You get your vitals done, and then all of a sudden the doctor says, hey, your blood pressure is a little elevated. So typically, when it comes to measuring blood pressure, there's one particular thing. Oh, I see what's going on. That's what happens when I plug this in. Okay, so I'm not going to be able to plug that in. So typically, what happens when it comes to measuring blood pressure is pretty much defined as how hard your heart has to pump against the arteries to get blood out of itself. So put it like this. You know that your blood carries oxygen to the rest of the body, very important to your organs, your cells, your other nutrients. So when your heart pumps, your blood pressure is pretty much the force that your heart has to pump against. So when your arteries are very narrowed, that means your heart has to pump extra hard to get blood to the rest of your body. So the more narrow your arteries are, typically the higher your blood pressure is. So that is why treatment is aimed at relaxing your arteries so your heart doesn't have to pump as hard. Now, it is very important that you catch high blood pressure because if your heart keeps having to pump at that hard rate, your heart may eventually get tired and give out. Okay. So pathophysiology, we just talked about it. Your heart has to pump extra hard against your arteries, which are very narrowed. What is another term for narrowed arteries? If I say that a person has narrowed arteries, what is the medical terminology for that? Anyone knows, you guys can type into the chat. Not so much stenosis. That's a good guess. Stenosis is when your arteries get atherosclerosis. So I see where you guys are going. So when you have atherosclerosis, which can cause high blood pressure, you guys are actually on the right track. Vasoconstriction. Yes, Miss Cox. Thank you. So typically you can have vasoconstriction and not necessarily have atherosclerosis. But yes, you definitely can have high blood pressure from narrowed arteries in what you call atherosclerosis. So you guys are actually correct. So these are the risk factors, okay? Age, ethnicity, African Americans, highest risk factors for high blood pressure. It is genetic. So if you do have some people close to you in your family, a mother, a father, grandparents, sisters, it is very likely that you also can be affected by high blood pressures. Usually people who have certain conditions like diabetes, there is a comorbid, meaning you may also have high blood pressure if you have diabetes or if you have kidney diseases. And then you have some people with the unhealthy lifestyle practices. So poor eating habits, eating a lot of salt, okay? A lot of alcohol, believe it or not. Let me see if you guys know, what is the connection between increased alcohol intake and blood pressure? It is the same connection with smoking and blood pressure. What is that connection? What does alcohol and nicotine do that causes an individual to have increased blood pressure? Constricts. Okay. And believe it or not, excessive alcohol take and smoking does cause vasoconstriction. Okay. So for those individuals who do smoke a lot, for those individuals who drink a lot of alcohol, very likely that their blood pressure is elevated. And then, of course, obesity. Okay. So a lot of times for some individuals, regulating blood pressure is just as easy as stopping the smoke or cutting salt out the diet or losing weight. Okay. So manifestations, again, known as the silent killer. However, how do we determine that individuals has high blood pressure? We will have to measure elevated blood pressure on more than one occasion, just to make sure, because some people have what we call white coat hypertension. When an individual has white coat hypertension, that means whenever they go to a hospital or whenever they go to the doctor's office, you know, that fear of getting needles or shots and the doctors, the pressure elevates. I actually have white coat hypertension. Whenever I go to the doctor, my pressure is elevated because for some reason, just doctor's offices makes me nervous. I don't like needles. I'm that type of nurse. I don't like needles. Listen, I could give somebody else a shot all day, but me, when it comes to me, I'm horrible. So I do have white coat hypertension. You know what? Listen, it's bad. I'd be like, wait. If I gotta get like I'd be like, hold up. I gotta draw blood or something. I'd be like, wait, give me a second. Let me breathe. My doctor like, now you know, listen, my doctor be like, you too old for that. I'm like, yeah, but
Then professor will ask you and you say you're a nurse and they look at you.
listen, nurses, somebody said nurses makes the worst patient. That is absolutely true. The worst. Listen, I have started IVs on NICU babies. Listen, I can use a needle all day on somebody else. But me, I am not a needle fan at all. So we've already talked about other manifestations. Remember, people who have untreated high blood pressure for an extended period of time, you start seeing issues with other body system managing. So usually the eyesight, the kidneys, you may even start seeing signs of coronary artery disease, angina, also known as chest pain. Some people may start having cardiac arrhythmias. In worst case scenario, you start having myocardial infarctions. In worst case, even beyond that, heart failure. Okay. A lot of people, when they have chronic headaches, one of the first questions I ask, what's your blood pressure looking like? Okay. Some people, they have strokes because their blood pressure is uncontrolled. For a lot of people, that is the sign that they even have high blood pressure. Again, they don't have any manifestations. And then all of a sudden, out of the blue, they have a stroke. You come to find out your blood pressure has been elevated for some time. People who have easily nosebleeds. Okay, if you are someone your nose bleeds very easily, I'll also ask them, what's your blood pressure looking like? Okay. So treatment, very simple. Okay. Now, first we start with lifestyle management. Okay. We'll do things like, listen, we need to cut that salt out the diet or cut back. Now, I know my people, listen, we know we can season some food, right? We are the worst, very, very heavy handed when it comes to the salt. However, we would have to figure out a better way to make that food taste good. You know, they do have low sodium alternatives, they have no salt. alternatives, and that's what we usually. Exactly. So usually we try with the lifestyle modifications. We also say, listen, try to get some activity in your lifestyle. Some people are very sedentary. They don't move around a lot. Walking is very beneficial. Okay. We'll tell you to stop smoking. Now, I know a lot of people can't quit cold turkey because nicotine can be addictive. So we may put you on some type of a smoking cessation program. Okay. Also, cut back on the alcohol. Believe it or not, there is diet alcohol. And you're probably like, what is that? There are healthy, if you believe it, healthy alcohol options for people who just want to enjoy alcohol. There are healthier options. Does it taste the same? Probably not, but it is a healthier option because we do want you to cut back on your alcohol intake. So, pharmacological wise, how do we manage hypertension? So, one of the first medications that we do prescribe would be a diuretic. Okay, so question, critical thinking, how would a diuretic help you to lower your blood pressure? Because again, if this was a question on the NCLEX, okay, what would I be looking for? If I gave my client a diuretic to lower blood pressure, what would I expect to happen? Diuresis. So be more specific. You are correct. How exactly does diuresis help with lowering blood pressure? Increase urine output, and what would be released in that urine? You guys are absolutely correct. So what should I expect my client? Now, ketones is something you see when you have high glucose. So electrolytes, exactly. The whole purpose is for you to release a lot of fluid, so your urine output increases, and we expect you to lose a little bit of sodium chloride, which is salt. Okay. Now, sometimes there will be another medication prescribed, beta blockers. What is the purpose of beta blockers? Vasodilators. They are exactly what they sound like. I would expect my arteries to do what? If I'm taking a beta block, a vasodilator more specifically, I would expect my arteries to dilate. Exactly. So remember, the more constricted your vessels are, the harder your heart has to pump. So if I get a diuretic with a dilator, okay, not only as I'm getting rid of all of that extra sodium, but my arteries are also going to dilate. My heart should not have to pump as hard. Okay. And then you have your other medications, your ACE inhibitors, calcium channel blockers. Calcium also increases the workload of the heart. So everything just falls into just getting the heart to relax a little bit. Your heart is a muscle at the end of the day, and we do not want our heart to be overworked because the heart will get tired. And that is how people fall into heart failure, which we will also talk about. Okay. Oh, I'm checking the chat as you guys talk. Okay. Now, let's just jump right into myocardial infarction since we're doing so good on time. So, what exactly is a myocardial infarction? So, another name for heart attack. Now, there are many different ways that an individual can experience a heart attack. But in general, when there is a blockage of blood flow, now remember, blood carries oxygen. Okay. So, in a sense, when your heart is not being perfused as well as it should be, you are increasing your risk for having a myocardial infarction. What happens is, since your heart is a muscle, the heart muscles will start to die off. Whatever area is not getting perfused appropriately, that area will start to die off. That is what leads an individual to have a myocardial infarction. Now, how much damage will be done? It depends on how much perfusion the heart did not. A deoxygenated area, exactly. Look at y'all. Deoxygenated area, exactly. Typically, a lot of people they have myocardial infarctions and they might not even realize they're having one. A lot of times you think you know what you see in the movies, people grabbing their chest and then they're falling out. That's not always how it happens. Okay. Some people have very, very, very minimal chest pain and they're not realizing they have had a myocardial infarction. Oh, somebody is drawing. Give me a second. For those of you who are joining for the first time, you should have saw me in the beginning trying to get these lines off the screen. I'm a pro now. Uh-huh. Troponins. Look at troponin levels, exactly, which we will get into. Typically it is a medical emergency. Now, the quicker you react, the easier it is to manage and the quicker the client will recover. Okay. What we don't want to happen is we don't want a myocardial infarction to lead into heart failure. Okay. Once a client goes into heart failure, it definitely becomes a little bit harder to manage. That is why we promote health promotion. We promote, you know what, don't wait to go to the doctor because something is wrong. You should keep up with your histories and your physicals just to make sure everything is going okay. Because again, silent killer, high blood pressure, untreated can lead to an individual having a myocardial infarction. Okay. So pathophysiology, know your terms. Okay. When you guys take the NCLEX, you got to know your medical terminology. You got to be comfortable. Okay. So first things first, when it comes to a myocardial infarction, you have a condition that is called ischemia. Okay. Ischemia is when you have a decrease in blood flow to a particular area of the body. So what you guys think, critical thinking, what do you guys think could decrease blood flow to the heart? Now we get into our conditions besides high blood pressure. And some of you already mentioned it very, very early in the presentation. You guys mentioned it, atherosclerosis. Okay. When you have plaque buildup in your vessels, that can decrease blood flow. Hyperlipidemia.
A clot.
Exactly. Say it again. Clots? Oh, absolutely. Clots, one of the most common causes for blockages of blood flow and perfusions to particular areas. Absolutely. All of you are right. Clots, cholesterol, high blood pressure, atherosclerosis. So that is what we're trying to prevent from happening. Okay. Now, what happens is when you have a prolonged ischemia going on, you're going to start having necrosis of tissue and cells. Necrosis is death. Okay. So the area will die off due to the lack of proper perfusion or lack of oxygenation. What happens is when the area dies off, it will trigger an inflammatory response. That is the myocardial infarction. So again, very quickly, ischemia, decreased blood flow to a particular area, decreased perfusion to a particular area. When you have an extended lack of perfusion, the area, the tissues, the cells, they will start to die off. It's called necrosis. Once you have so much necrosis, a inflammatory response will be triggered, and that is when the individual typically has the myocardial infarction. So when it comes to risk factors, two types of risk factors, and this is also important in NCLEX information, modifiable and non-modifiable. So when I say a person has modifiable risk factors, what is that exactly? So if I say modifiable risk factors for a myocardial infarction, I am
Something you
saying
can
Things we
change.
can change.
there it is.
Lifestyle.
Perfect. Something you can alter, something you can control. Okay. So obesity, you can control your weight. Okay. Sometimes something as simple as losing weight decreases your risk for a lot of cardiovascular issues. Smoking, going back to smoking. Okay. Inactivity. A lot of people who are sedentary. So if you see the term sedentary, that is people that are very inactive. You sit all day, or you have coexisting conditions. So if you have hypertension, you need to get a control on it right away, because the longer you have hypertension or the more that it is not controlled properly, you increase risk for myocardial infarctions. Also, coronary artery diseases. Okay, which we do have a presentation. I think my second presentation or something along the lines, I will be covering or coronary artery diseases as well. And then you have your non-modifiable risk factors. So what are my non-modifiable risk factors? What does that mean? And I am
What you
checking in the
cannot
chat.
change.
Yes, ma'am. Thank you very much. Those are factors that you cannot change. Those are factors you have no control over. Getting older. Listen, getting older, cardiovascular system changes, that's just a part of life. That is one thing that we cannot outrun. You can eat as healthy as you want to eat. You could be as active as you want to be. We cannot outrun getting older. Okay. Now, there's a lot of treatments that we could do, to knock off a couple of years that we don't look our age. But that is one thing we cannot control. Yes, family history. You cannot control genetics. You cannot control the things that you inherit from your parents, the things that you inherit from other family members. And yes, cardiovascular disease does run in families. Gender. Now, it is one thing to identify with a particular gender, however, or sexual preferences. However, science, you cannot alter that. Gender is something that you cannot control. And women, higher risk for cardiovascular diseases over men. So a lot of times we see women with the heart attacks, the high blood pressure, and the other cardiovascular issues. Okay. So I see myself treating a lot more females than I do males when it comes to heart diseases. How do you modify coexisting health complications? That's a great question. So, for example, if I have obesity, okay, that is a health condition. So, how do I modify it? I lose weight. If I have hypertension, okay, I modify it, making sure I take my medications on time, make sure I follow dietary restrictions, make sure I get active. Believe it or not, 3 days a week, 30 minutes of walking makes a huge difference on a person's obesity and the high blood pressure and all of that. Okay, exactly. Diet, exercise, those are the things that you can change. Okay. Now, manifestations of myocardial infarctions. One of the most common things we see, angina, also known as chest pain. Okay. Now, people describe chest. First of all, before I ask this question, before I say this, what type of data is angina? If a person tells me that they are experiencing angina, how would I classify that? What type of data is that? Now, this is going back to fundamentals. Stable, unstable, pain that can be relieved by rest, subjective. Thank you. You guys are all correct. It is subjective data. So, what does subjective data mean? If I am saying that I am recording subjective data, I am specifically what
Something
the
the
client
patient is telling you,
exactly. So, when a
something you
person
cannot measure.
you cannot measure it exactly. So basically, it is what the client tells us that they are experiencing. So a lot of times when a client says that they are experiencing angina, we ask them to describe it. Okay? Because chest pain could be a couple of different things. It doesn't necessarily have to be a myocardial infarction. You can have heartburn and you can have chest pain. You can have gas. You can have chest pain. You can have a respiratory issue. It has nothing to do with your heart altogether. And you can experience chest pain. So we kind of get some questions in to try to figure out what exactly is going on with the client. So if they do describe it, they might describe it as squeezing, pressure, tightness. I had one client said it felt like somebody was sitting on his chest. That is how he described his angina, or it could be burning. Now, sometimes pain radiates. That is a huge clinical manifestation. Now, when it comes to the NCLEX and we talk about signs and symptoms, it's very important that you guys know signs and symptoms. And there are different types of signs symptoms. When you see the term clinical, okay, clinical manifestation means if I see this particular sign and symptom, I automatically think of this particular condition. Okay, I'll give you an example. Fever. Fever is a manifestation for a lot of different things. If a client tells me they have fever, I have no idea why they have a fever. It could literally be anything. However, if a client tells me that they have pain and that pain is radiating to their left arm, radiating to their shoulders, radiating to their back, pain that radiates to their jaw, that kind of narrows down what exactly the client is experiencing. Okay, shortness of breath. You have some clients that they say they have a hard time breathing, they have a hard time catching their breath. Some clients experience nausea and vomiting. That is something that we typically don't think about when a client is having a heart attack or myocardial infarction. Okay, dizziness, lightheadedness, so fainting. Okay. Diaphoresis, profused sweating. That is another manifestation that a lot of people don't think about when it comes to a myocardial infarction. Heartburn, indigestion, one of the less common manifestations. Okay. Fatigue and just the feeling of anxiety and anxiousness. A lot of times people just feel anxious, like something is wrong, something is not right, something is happening. I always tell people, trust your gut. Trust your instincts. Okay. If you just have this unsettling feeling, a lot of times when people are hemorrhaging, a lot of times when people have respiratory issues, they have this unsettling feeling, this anxiety within themselves. That is not something you should ignore. Okay. So these are your clinical manifestations for a myocardial infarction. Now, let's talk about how we would diagnose a myocardial infarction. So, very simple. First thing, we look at the history. Okay. Again, typically we're going to see, what was going on leading up to this particular moment. Did you have any coexisting conditions, hypertension, hyperlipidemia, obesity? We're going to take a look back to see, what was going on. We're going to talk about dietary history. How do you eat? Because again, hypertension very well can lead to a myocardial infarction if it's not caught quickly. Then we will do what is called an electrocardiogram, an EKG or an ECG. Okay. If you see EKG, ECG, they mean the exact same thing. Okay. That is what exactly is an EKG? What you got? Let me see what you guys know. What is an EKG? If I and you're gonna get questions like this on the NCLEX, you have to explain procedure. So if I was a client and I needed an EKG, and this is the very first time, I have never had an EKG in my life, and I'm going to ask you, my nurse, what is an EKG? How would you describe it to me? Like what terms would you tell me an EKG is? I'm checking the chat. Picture of the heart, okay? More specific than that. You are correct, but it tells me something specific about the heart. Electrical activity, that's what it is. Perfect. So an EKG is going to tell me the electrical activity of the heart. Okay. If you have any heart related conditions, usually we start with an EKG. That is a very basic test, it is non invasive. Okay. The client just has to lay there. We're going to put some leads in very specific areas. How many leads are in an EKG? How many leads? 12. Thank you. 12.
12.
Okay. 12. So we're going to put 12 leads in different places. We're going to tell the client, just lay there and relax. And for a couple of seconds, we're just going to get a reading. Okay. You can tell a lot about an EKG. As a matter of fact, the EKG is what's going to help you when it comes to diagnosing a heart attack. Because again, if a person complains of chest pain, I really have no idea what that is. Sometimes the EKG is going to help me rule out a myocardial infarction. So it wasn't a heart attack at all. It was something else. Echocardiogram. Now, again, if I was a client, never had an echo in my life, how would you explain an echo? So the key word is echo. What is an echocardiogram? I'm looking in the chat. What is an echocardiogram? So if an electrocardiogram gives me the electrical activity of the heart, what is an echocardiogram going to give me?
Wave.
You are correct. A wave, sound wave, pictures. Exactly. So if I was under the impression that I had a client and there was issues with blood flow, okay, an echocardiogram would tell me that because a lot of times myocardial infarctions again is due to the fact that there's problem with blood flow. The heart is not getting perfused appropriately. So with an echocardiogram, you're going to get a picture of the heart. And this picture is going to show me my chambers. This picture is going to show me my valves. This picture is pretty much going to show me how blood is flowing. Okay. And if there is a problem with blood flow, the echo use because and it's usually it's an ultrasound. So somebody did say sound waves. The ultrasound of the heart is going to help me determine what issues or what areas of blood flow I'm having. Okay. And then laboratory testing. Now, of course, you can do your basic CBC. Okay. But there is one lab in particular that I'm going, troponin, exactly. If I was to do some blood work, I'm going to look for the troponin levels. When you have damage to the heart, those levels in your blood are elevated. See, these are the types of things you need to know for the NCLEX. Very basic. Labs is always important to know for the NCLEX. It's like, what lab in particular am I looking for? So troponin levels, very important when diagnosing damages to the heart, myocardial infarctions. Okay, I'm checking the chat. I see you guys are talking. It is elevated. BNP is for heart failure. Okay, troponin, yes. Okay, look at y'all on top of it. Okay, and then lastly, of course, family history. Again, one of those things you just cannot, cardiac markers as well, absolutely. One of those things you just cannot get away from, family history. Okay. It's like no matter how healthy you are, I mean, it does help, but again, if it runs in your family, your risks are immediately elevated. You could be the healthiest person on the planet. And it's kind of like, people say things like, how does a person who's never smoked a day in their life, how do they develop lung cancer? A lot of times it's just something genetically in the body that you cannot control. Remember, this is a non-modifiable risk factor. So because it is non-modifiable, the best thing that you can do is just make your body healthy from the beginning. If you know heart disease runs in your family, then you automatically need to eat healthy. You need to exercise. Okay, you need to keep up with doctor's appointments. Don't go to the doctor because something is wrong. Go to the doctor to make sure everything is still okay. Okay, a lot of times people are what we call reactive. A person that is reactive means they go to the doctor because something is wrong. A proactive person, they just, it's time for my physical. I feel good, but I just need to make sure that everything is going okay. Okay. Now, treatment for myocardial infarctions. Now, on the NCLEX, okay, prioritization is very important. What do you do first? What is the most important lab? What else? Who would you see first? So when it comes to emergent care, emergent is the same thing as emergency. Sometimes when we talk about prioritizing nursing interventions, prioritizing clients, who do we see first? You look at the acute emergent things. Okay. When you are talking about something emergent, this is something that can have a direct effect on the person's life. It could be the difference between life and death. So when it comes to managing a myocardial infarction, the quicker you act, okay, the higher the chance the person's life can be saved, or you limit the complications or damages that can be done. So we tell clients, if you have any chest pain, you seek medical attention immediately. Okay, especially if you have a history of cardiovascular disease. Immediately, we're going to do an EKG. We need to determine if this is a heart attack or a myocardial infarction, or again, if it's something else. We're going to, of course, get our blood work, our labs. We're going to do our basic CBCs. We're going to look for cardiac markers. We're going to look for troponins. Okay, and then routine oxygen. Now, oxygen is one of those things that you got to be careful with. A lot of students think you always throw oxygen on individuals. You actually don't. You can kill someone if you mismanage oxygen. Okay. Too much oxygen is actually not a great thing depending on the person. So, oxygen is something that's going to be standby if the client needs it. For example, they're having respiratory difficulties or their oxygen saturation levels are low. Okay. Nitroglycerin. So, what is nitroglycerin? How do I use nitroglycerin? Now, of course, pharmacology is also very important for the NCLEX as well. So, Mona, Afram, Kelsey, absolutely. I did hear about that. Morphine, oxygen, nitroglycerin, and aspirin. Absolutely. Sublingual vasodilator, a quick vasodilator. So usually how they nitroglycerin works, you're going to get these tabs and you're going to place them under the client's tongue. Now, how many times can I give a client a nitroglycerin tablet if they're experiencing angina or chest pain? 3 times. Look at y'all. 3 times. Absolutely. Okay. Usually, okay, if it is something that we caught early, 1 or 2 might be all that we need, but you can give nitroglycerin up to 3 times. How far apart? Sublingual. And you guys are correct. Sublingual. Every 5 minutes.
5 minutes.
3 to 5 minutes apart. Look at, okay, look at y'all. Okay, then. Absolutely correct. Okay, now someone mentioned aspirin. Kelsey mentioned the acronym MONA, aspirin, anticoagulation. So, what is the purpose of aspirin? Heparin can also be a part of this therapy as well. Anticoagulant. So, what do? They prevent what? They
Bleeding.
prevent
Blood clot.
clotting. Okay. If you had a myocardial infarction due to clots, okay, remember ischemia, reduced blood flow to a particular area. If this was caused by blood clots, then you will be placed on anticoagulation therapy, meaning you may take low dose aspirin daily, or we may give you some heparin. Now, very important with the education that comes with this. Okay, because your blood does not clot normally, you are at a risk. You're at a risk for hemorrhaging. So the education that goes along with anticoagulation therapy, the client needs to be needs to be careful because it's very important that they reduce injury to reduce the risk for bleeding. Okay, exactly. See, that's the part of the NCLEX. Exactly. You got to figure out how does all of this tie together. Somebody mentioned in the chat using an electric razor. Absolutely. You don't use a regular razor, you use an electric razor. So little things like that, the education. Okay. I have a client that's being placed on anticoagulation therapy. I have a client that is placed on aspirin therapy. What is important for me to teach the client? What should I include in teaching? How do I know that teaching is effective? I have a client that's taking an anticoagulant. Okay. And then, of course, morphine. Now, what does morphine have to do with a myocardial infarction? What would you do first, the EKG or oxygen? That is a great question. Okay, so can someone answer that question? I did ask about morphine, but someone asked a really, 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 really great question. What would you do first, you guys?
It will relieve and also dilate the
Oxygen.
capillaries.
Oxygen first.
Now, now let's talk about it. What if the client is not showing any signs of respiratory difficulty? Would you still put oxygen on them?
We'll
No,
do EKG
Professor.
first to
EKG.
assess the condition of
No.
the patient.
Only if they are in distress. Absolutely. That is something you guys have to keep in mind. Now, you have your frameworks like ABC, right? Airway, breathing, circulation. You have Maslow's to help you prioritize. If your client is not in distress, you do not need to put oxygen on them. Okay. Your priority is the EKG. Not every client that has a myocardial infarction or every client that has chest pain needs oxygen. Remember, if your client's O2 saturation is within normal limits on room air, they do not need oxygen. Okay. As a matter of fact, you have to be careful with oxygen because if you have a client with certain conditions like COPD, you definitely don't rush to put oxygen on them because you could kill them. So if the client is not showing signs of distress, no respiratory distress, you do not need to put oxygen. Your priority would be the 12 EKG lead. Okay, so going back to morphine, morphine not only relieves pain, it helps with the anxiety. Okay, it helps to calm. Listen, when you have a heart that is overworked, if you have a heart that is stressed out, tired, I want to decrease the demands on your heart. What does that mean? I want to calm you down. Okay, I want to calm you down. I want to calm your heart rate down. I want to decrease the workload. Exactly. Morphine is going to decrease the workload. So think about it. If you're carrying 10 pounds and I take away 5 pounds, now you're only carrying 5 pounds, the load becomes easier to carry. That's kind of sort of what morphine does. It kind of reduces the workload of the heart because the last thing we want to happen, we don't want your heart to continue to be overworked because then that leads to heart failure, which we will also talk about tonight. Okay. Now, long-term management. So these are the types of questions you see on the NCLEX where, the nurse just finished doing some discharge teaching. What statement indicates teaching was effective? Okay. Or the nurse needs to do teaching about a particular medication. What is important to include in teaching? Okay. So a lot of times with the long-term management, it is focused on maintenance. It is focused on rehabbing, getting better. Okay. Does the client understand what needs to be done for them to recover from this particular condition? Rehab, listen, discharge starts exactly, Kelsey. We start getting ready to discharge you as soon as you admit it. Okay. That's what clients don't know. Listen, as soon as you get up in here, we trying to get you up out of here. So discharge planning starts the moment a client is admitted. Absolutely. Okay. Or follow up something patient are doing wrong. Yes. Okay. So rehab, medications, depending on the client's needs, that is going to determine the type of medication they will be placed on. So for example, an anticoagulant. Okay. Now, anticoagulants only reduce the risk of clots. What if the client already has clots? So if I put a client on an anticoagulation therapy, I'm trying to prevent the development of new clots. Okay. If the client already has blood clots, then what type of medication may I put them on? Thrombolytic. Now, heparin is a anticoagulant. Okay. Heparin reduces the formation of new clots. So if the client already has clots, heparin will not work. It will not be effective. You're going to have to give the client something that's going to bust or strip or dissolve, break down. All of those words are the same. Existing clots. Okay. You guys are in the chat. Absolutely correct. T-Pay, I see you. Streptokinase, I see you. Absolutely correct. Okay. Now, lifestyle modifications. Listen, you just had a myocardial infarction. That's like a warning sign. Okay. If you do not change your lifestyle habits, something worse can happen, such as heart failure, or even worse, a massive myocardial infarction. So, we're going to talk about dietary changes. Of course, listen, you need to cut back on that salt. I had one client, my food needs to taste a certain type of way. You're gonna have to find something else because what you're using apparently is not working. Usually with those type of clients, I do refer them to like a dietitian. It is okay to make referrals to dietitians and nutritionists. Okay. Exercise programs. Listen, you need to start walking. Just get a step counter. Walk at work. Try to get some increased walking in. Take the steps instead of the elevator if you can. Okay. Try to increase the cardio some type of way in your exercise routine. And then, of course, you need to cut back on the smoking. You need to cut back on the drinking. Why? What do the client says? Why? What does smoking have to do with my heart? What does alcohol have to do with my heart? Because you do get questions like that on the NCLEX. Okay. You need to stop smoking because it causes your arteries to constrict. It makes your heart work more. You need to stop drinking because alcohol makes your arteries constrict, or they make your arteries get smaller. That's going to make your heart pump harder. Can we use what is MAM? I'm not familiar with the abbreviation. Rosie, if you can break that down a little bit better. So statins are more like for your cholesterol medication. So if your myocardial infarctions was, tied to your high cholesterol, hyperlipidemia, then yes, a statin medication will be thrown in there somewhere. Okay. Look at y'all. Then of course you need to keep up with your routine visits. You're gonna do some follow-ups. Okay, we're going to do a lab, we're going to do some EKGs. We're just going to make sure that everything is working appropriately. A lot of times when clients are not getting well, usually it's non-compliance. It's not that the treatment is not working. The client is not following up with the treatment. They're not taking their medications like they're supposed to. They haven't changed their eating habits. So the follow-up appointments are very, very important for us to make sure that you are on the right track for recovery. Okay, so complications. Now, let's just say I have an individual and they are not being compliant with the care plan. They are not following orders and they experience further complications. One of the most common further complications would be heart failure, which we will talk about next. Okay, cardiac arrhythmias. Now, there's also a presentation that I do where I cover cardiac arrhythmias, which is also very important for you to know for the NCLEX. The heart rhythms. There are some heart rhythms that are very deadly. And if you have a overworked heart, if you have a heart that is giving out, you're going to start to notice maybe my heart's feeling a little different. Sometimes people feel when they have a cardiac arrhythmia. And then You can have issues with the other body systems. If my heart is not pumping effectively, if my heart is not pumping out oxygenated blood, my brain can be affected. Now I'm at a risk for stroke. My kidneys are affected. I'm at risk for kidney failure. My liver is affected, and so forth and so forth. Okay. So let's take our first breather. That was really, really great. So it is 9:55. First of all, are there any questions? I know that someone did ask a question in the chat. Rosie, if you can just further break that down or explain that question, because I'm not 100% sure what you're asking me, but just break that down a little bit better and we come back from break, I'll extra. Thank you, Kelsey. I try with the lectures. I try. So let's take a breather. It's 9:55. So let's do 10 minutes. Okay. 10:05, you guys, we will be back and we will knock out heart failure.
Time up.
Damn. Drinking. When you lecture a lot, your voice gets a little tired. Okay. So welcome back. Okay, just checking the time. So now we are going to get into heart failure, a very, very big, important concept when it comes to cardiovascular conditions. Definitely information that you are likely to see on the NCLEX, especially when it comes to medication management. So let's get into it. So first up, very simple, what exactly is heart failure? Now, the misconception is when a person has heart failure, they automatically die. That is not the case at all. When we define heart failure, we simply say that the heart is no longer able to keep up with the demands of the body. That means your heart is tired. Your heart is tired. Your heart has just given out. It can no longer keep up. Okay. Typically, you can have a weakened heart or you can have muscles that are not able to contract appropriately. That could also increase your risk for developing heart failure. Depending on the type of heart failure that you have, you're going to see different manifestations, which we will go into. And honestly, it can be reversed pretty quickly if it is caught early. So that means you need to be on top of it. If a person has hypertension, if a person has experienced a myocardial infarction, if a person has clots, coronary artery disease, any type of cardiac condition that increases the risk for developing heart failure, we need to be on top of it. It needs to be managed appropriately because if it does happen, we catch it quickly, okay? And we can lessen the damaging effects that happens if a person does experience heart failure. Okay. Now, when a person has heart failure, we classify it based on limitations. So, what does that mean? Okay. And this is also typical NCLEX material if you do get it. We classify your heart failure based on your activity tolerance. So, for example, if a person runs up some steps, okay, or if a person exercises something strenuous for an extended period of time, I expect that person to be out of breath, right? That makes sense. Your body has to recuperate from all that activity. However, what if a person is just sitting down? What if a person is sleeping? Now, my question is, why is your heart rate so high and you're resting? Okay. Why are you breathing so fast and you are resting? So, when it comes to classifying the heart disease, we typically look at what your activity tolerance is. Okay. If you can still engage in activity, you don't get tired very, very easily, then you're on the lesser end of the heart failure or the cardiovascular issue. However, if you're tachypnic at rest, what is tachypnea? If I say a client is tachypnic, what am I saying? If I say a client is tachycardic, what am I saying? Tachypnic and tachycardic, what is that? Because that is how we judge how serious your heart disease is. If you are tachypnic or tachycardic at rest, then you have a very serious, exactly, your heart rate's too fast. What about tachypnic? What is tachypnic? So tachycardic, yes, your heart rate is way too fast. You have high respiratory rate, exactly. So if a person is at rest, meaning they're sitting down, watching TV, reading a book, they're not engaging in any physical activity, they're even sleeping, and they are tachycardic or tachypnic, that is a really, really, really red flag sign. That will need to be reported to the physician. So that means that person is on the high end of cardiovascular issues. So these are your risk factors for heart failure. Okay, again, coexisting conditions. Now, we've seen this throughout this whole presentation. Okay, hypertension, diabetes, coronary artery disease, high blood pressure, high cholesterol, hyperlipidemia. All of these increases your risk for developing heart failure if those conditions are not caught early and managed effectively. Smoking, again, remember, nicotine causes vasoconstriction. So now I have a heart that has to pump harder, work harder, and eventually my heart will get tired because your heart is a muscle at the end of the day. A tired heart is a heart that's going to give out. Sedentary lifestyles, you're not active. Okay. Ethnicity, unfortunately, in cardiovascular disorders, risk factors are pretty much they're all linked. Same thing with respiratory. Okay. Oh, and also before I forget, I just realized it. The question that Rosie asked me, the answer is no. Okay. I just thought about it. The answer is no. Okay. And the reason why the answer is no is both of those medications are anticoagulants. So I see why you asked that question. The issue is they both work differently. Okay. Aspirin works on platelets. Okay. That is why aspirin is usually the go-to for managing, after a myocardial infarction. The rivaroxaban, that medication is a clotting factor medication. So the aspirin works better. Now, you might be prescribed both of those. They do work together, but if aspirin is not available, that would not be the choice of medication. That does not work as well as aspirin. If aspirin is not available, you need to talk to the doctor and say, we need to find another solution because aspirin is the top of the line management post myocardial infarction. Okay. You're welcome. And then again, we talked about family history. So someone in the chat said that was Kelsey. Pretty much they are exactly linked. They are pretty much the same across the board when it comes to risk factors. So heart failure, you have what are called general manifestations. Okay. When it comes to heart failure, remember you have two types. Okay, because you have two sides of your heart. You have a right side, you have a left side. However, in the very, very beginning, I do not know what type of heart failure my client has. Okay. Does my client have right-sided heart failure? Does my client have left-sided heart failure? Or is it general overall, both sides? Because right-sided heart failure can eventually lead to left-side heart failure. Left-side heart failure can eventually lead to right side. So that means I could have one or the other side, or my heart entirely has given out. So your general manifestations, again, tachycardic, tachypnic at rest. You are resting, you are sleeping, and your heart rate and your respiratory rate is extremely elevated. That is usually a huge red flag sign. Okay. Dyspnea. What is dyspnea? If I document that my client is experiencing dyspnea, what have I observed? In the chat, shortness of breath, difficulty breathing. Okay. Activity intolerance. Listen, you cannot walk 2 steps without getting out of breath. That is how we measure also the level of heart failure that you have. Okay. Again, activity tolerance. Can you walk here and there without getting out of breath? If I have a client to ambulate from the bed to the bathroom and back, and they are so out of breath, you would have thought they ran a marathon. That is a red flag. Okay. Weight gain. That is a huge one. Now, when we say weight gain, it is not fat accumulation. It is because of fluid retention. Okay. You have a client that has overnight gained 5 pounds. Overnight, they've gained 10 pounds. And again, this is due to retention of fluids. And lastly, if we were to give you an EKG, which we should, it will show you have ventricular hypertrophy. That means the heart muscle of the ventricular chambers. So your right chamber, your left ventricular chamber, your right ventricle chamber, they are enlarged. The heart muscle is enlarged. Okay. Remember, when you work, okay, think of it like this. When you lift weights, I expect my muscles to grow, right? I expect my muscles to get bigger. I expect my muscles to get more defined. That does not work with the heart. That is a bad thing. You do not want the muscles of the heart to enlarge. An enlarged heart muscle indicates your heart has been working overtime. Your heart has been working more than it should. So in this case, an enlarged heart muscle is not a good sign. Like I would expect my arm muscles to grow if I was to lift weights. Okay. So again, if you do an EKG, it is going to show right ventricular hypertrophy most of the times. It could also show left ventricular hypertrophy as well. So now we get into the specifics. Okay. Right-sided heart failure. So in a sense, when we talk about heart flow or blood flow, when we talk about blood flow through the heart, it is very important that you guys know blood flow. Okay. The reason why it is important for you to know direction of blood flow, because when it comes to certain types of failures, when it comes to certain types of issues in the heart, okay, if you know the direction of blood flow, you will already have an idea of what type of manifestations I expect to see. For example, if you have a problem with the heart valve, where is that heart valve? That means blood backs up from that heart valve. I should expect to see XYZ symptoms. It's the same thing when you talk about left-sided versus right-sided heart failure. Now, let me check into the chat right quick. Okay, that's a great way to remember it. So what's cardiomegaly compared to ventricular hypertrophy? That's actually a question. Cardiomegaly is all around. Cardiomegaly is more heart muscles. Like, so you remember now you have heart muscles all the way around. When we talk about ventricular hypertrophy, we're talking about the ventricle chambers specifically. Okay, because remember, you have your atriums and you have your ventricles. So if you're talking about ventricular, you're just talking about that bottom part of the heart that is enlarged. Okay. So when it comes to left-sided versus right-sided, okay. So very quickly, let's talk about blood flow through the heart. Let's just go through it quickly. So blood is in my superior inferior vena cavas, right? Blood enters into my right atrium. From my right atrium, blood travels through a valve. It travels through the what valve? What's the first valve? Come on now. Tricuspid valve. Okay. Into the right ventricle. From the right ventricle, there's another valve, which is what's the second valve?
Mitral.
Nope, not mitral. You guys need to know this. This is fundamental knowledge.
Pulmonary valve.
Pulmonary valve. Perfect. Now, from my pulmonary valve, travels through my pulmonary artery to my lungs so it can get oxygenated. From the lungs, oxygenated blood enters into my left atrium. It will travel through a third valve. What is that third valve?
Bicuspid.
Bicuspid or mitral.
Mitral
Okay.
valve.
Perfect. Then it goes into my left ventricle, and then it will travel through one last valve. What is that last valve?
Aortic valve.
The aortic valve into the aorta, into the rest of the body. Perfect. Now, right-sided heart failure, that means blood is not able to enter into the right side of the heart from my vena cavas. So that means blood will back up into my vena cava, which means blood will back up into systemic circulation. So blood is not able to enter into the right side of the heart. Blood backs up. What manifestations do I expect to see? I expect to see a lot of organ enlargement. I expect to see hepatomegaly. What is hepatomegaly? Enlarged.
Liver enlargement.
Liver enlargement. What is splenomegaly?
Spleen enlargement.
Spleen enlargement. Now that is the lower vena cava, my inferior. Now superior vena cava wise, I would expect to see jugular vein distension. Remember, this is blood backing up into systemic circulation. You also may have a client complain of headache due to this backup of blood flow. Now, on the flip side, left-sided heart failure, right? Blood is supposed to leave my lungs oxygenated, and blood is supposed to enter into the left side of my heart. Now, if I have left-sided heart failure, that means blood is not able to leave my lungs. That means blood will back up into my lungs. That is why you have pulmonary manifestations for left-sided heart failure. So, pink tinge sputum. That means my client was to cough and they had sputum, it'll be a little pink tinge due to the backup of blood flow. If I was to auscultate my client's lungs, I would hear crackles due to the fluid buildup. Okay. What is orthopenia? If I say that my client is experiencing orthopenia, what am I saying?
Shortness of breath while lying down.
Exactly. Now, critical thinking question, because this is where priority starts to come in. If you have a client that is, say, heart failure, and they are experiencing difficulty breathing, what will be your priority action if they were laying flat? Difficulty breathing, I have heart failure.
Get off the bed.
You need to, exactly. See, a lot of students will put oxygen, right? This is why I said oxygen is not always the first thing that you do. For a lot of clients, simply raising the head of the bed will help relieve the orthopenia that they are experiencing. So you try that first, and then if they are still experiencing difficulty breathing, then you will go to apply oxygen. Okay. And then, of course, they're going to have a cough. Okay, they can have, of course, the productive cough, but they're going to definitely have a cough because of all of that fluid that is accumulating in the lungs. So, not only do you need to know your general manifestations of heart failure, but you also need to be familiar with right-sided signs versus left-sided. Remember, right-sided is systemic, blood backs up into circulatory systems. Left-sided is pulmonary, blood backs up into the lungs. Now, goals of treatment for a client with heart failure, very simple. Okay, I need to get this heart back functioning. Oh, I need to get this heart back functioning appropriately. Remember, heart failure is when your heart fails to meet the demands of the body. So, my goal is to get this heart to be able to meet the demands of the body. So, first goal, to improve cardiac functioning. So, this is where medications come in, and there is medications that you can give a client to improve cardiac functioning. However, there is one medication above the rest, most effective at contractility, because I want my heart to pump effectively. I want my heart to pump enough to move blood throughout the body. So, what medication do you guys think that is? This is one of the most potent cardiac medications to improve contractility of the heart. DIG, absolutely, digoxin. Okay, DIG. Now, thinking about DIG, because I did put this in the presentation, but I want to see if you guys know. Now, NCLEX material. What is an assessment that I have to do before I administer digoxin to any client? What must I do? Like automatic, I have to do it.
Heart rate.
Pulse.
The pulse.
Which pulse? Be specific.
The
Apical
apical.
The apical pulse. How long do I need to assess the apical pulse for?
For the full 1 minute.
1 full minute. Look at y'all. 1 full minute. So doesn't matter if it's a child, doesn't matter if it's an adult. You need to
No.
assess the apical pulse for a full minute. Okay. So that means you need to know your labs as far as heart rate. If I am to give DIG, that means my apical pulse needs to be at a certain number or above. Now, typically for adults, what is the lowest apical pulse that you can have before you give DIG? The lowest minimum.
less than 60.
60 beats. Perfect. Absolutely. 100% correct. 60 beats per minute. So, NCLEX question. I'm about to give DIG. I assess the apical pulse. The client's apical pulse is 62 beats per minute. What should the nurse do? Administer DIG. Very simple. On the flip side, I assess the pulse for a full minute. The pulse is 58. What should the nurse do? Hold the DIG and then notify the physician. Okay. Now, removing all of that fluid that you have accumulated, somebody put it in a chat already. Diuretic. Most common diuretic, of course, is what?
Lasix.
Lasix. Furosemide. Absolutely. Lasix. Now, as a nurse with a client taking DIG, taking Lasix, I need to monitor my clients for certain things. Okay. DIG is a very, very toxic medication. That means your client can develop DIG toxicity. So that means you guys need to know the signs of digoxin toxicity. Now, just the value, because sometimes labs don't come back right away. So if I'm waiting on a lab and my client is showing signs of DIG toxicity, if I don't know what it looks like, I could potentially harm my client. So don't always rely on lab numbers. You need to know your signs and symptoms of DIG toxicity: respiratory depression, altered levels of consciousness. What else? Decreased urinary output.
Hello, visual disturbances.
Absolutely. Now, for Lasix, the goal is to get rid of all of that fluid. So what labs do I need to pay attention to? Because while I'm getting rid of all that fluids, there's something that I need to monitor while I have a client on Lasix.
Potassium.
And sodium. Perfect. Electrolytes. The goal of Lasix, the goal of a diuretic is to get rid of all of that extra fluids. That means I have a risk for electrolyte imbalances, potassium and sodium. Now, if I have a client that is hyponatremic, 2 levels low sodium, I'm going to see neurological disturbances. If I have a client that's hypokalemic, low potassium, what am I going to see? Cardiac arrhythmias. What else? Absolutely perfect. So you guys know, if you have a client for whatever reason taking Lasix, you need to monitor your labs, okay, your electrolytes specifically. Now, another NCLEX question. How do I know my Lasix is working? If the question was to ask you, what is the most effective way to determine that Lasix is working, what do you guys think that would be?
The way?
The weight, absolutely. Now, keep in
Daily
mind,
weight.
those types of questions are tricky because the answer options that they're going to give you, all of those are ways you can determine if Lasix is working. If the client has increased urinary output, the Lasix is working. Okay. If the client, let's say they had pitting edema, because a lot of times when you accumulate a lot of fluid, you have pitting edema. They're not having pitting edema anymore. Okay. But the most effective way to evaluate Lasix or any diuretic is to weigh your client. And you weigh them every morning using the same scale, typically before breakfast or any type of intake. Perfect. Now, decreasing cardiac demands, very simple. You need to rest. You need to sit down. You need to rest. Okay. So if I have a kid and their kid is crying, listen, crying is going to increase the workload of the heart. So your goal is to make your client comfortable. The more comfortable they are, the more calm they are, the less the heart has to work. And then when we talk about tissue oxygenation, if the client is experiencing any respiratory difficulties, that will be your cue to put oxygen. Okay. Remember, oxygen you don't always throw on people unless they absolutely need it. Okay, so those are your treatment goals for a client that is experiencing heart failure. So, special considerations, these are the things we just talked about. Okay, that's why I want to see, did you guys know before I got to this slide? So, again, for DIG, make sure you assess the apical pulse for a full minute. Okay, for an adult, 60 beats per minute is the minimum for you to give DIG. If the client's apical pulse for a full minute is less than 60, the nurse should hold the DIG and they should notify the physician. Now, critical thinking question. What if you forget? Let's just say, not saying that nurses would do that, but let's just say you forgot to give DIG and you said, oh my God, I forgot to give DIG and it's coming up on the next dose. Do you double the dose? Yes or no?
No.
No.
Absolutely
No,
not.
not at
You
all.
you absolutely do not. Okay, you notify the physician, or if this was client education, listen, do not double your dig. You just pick it back up at your next scheduled dose. Okay, what if your client vomits? You gave the client dig and they vomited. Do you repeat the dose?
Or the medication.
You do not repeat the dose.
No.
These are special considerations. Okay. And then we talked about managing dish toxicity. Also, again, for your diuretic. Okay. Best way to assess effectiveness, weigh the client daily. Of course, there are other ways to determine that your diuretic is working. However, best, most effective, those are the things you see on the NCLEX. Okay. Best way, weight in terms of water loss. Okay. You want to make sure you monitor your electrolytes, potassium and sodium. Okay. So that means you need to know your signs for hypokalemia, hyponatremia. Okay. And then, of course, for oxygen, monitor respiratory function. If there is no need for respiratory difficulties management, then there's no need for oxygen. We only use oxygen if it's absolutely necessary. So that means you need to monitor your respiratory status. You need to monitor your O2 stats. Okay, perfect. Complications of heart failure. So, if I have a client with heart failure and it is not being managed appropriately, these are the complications that I could see. Arrhythmias, valve damage. Now, worst case scenario, when your valves are damaged beyond the point of repair, they will need to be replaced. Sometimes heart valve damage is so severe, there is no surgery, there's no medications, nothing that can fix it. The issue with that, if you have mechanical valves, you are always going to be at risk for clot development because mechanical valves attract what we call vegetation, growth. Worst case scenario, those growth can break apart and they can travel through the heart. Next thing you know, I can have what is called a pulmonary embolism. Okay, clients can go into cardiogenic shock. You can develop CVAs, cerebral vascular accidents. Okay, organ system failures. My liver is failing, my kidneys is failing. Okay, and then of course, again, if you do have vegetations that break apart and travel, they can very well travel to the lungs, and now you have experienced a pulmonary embolism, which is emergency life-threatening. Any questions with our presentations? I am looking in the chat. I'm catching everything. Any questions? Perfect. Let's hop into our practice questions and let's see what you guys remembered. I see some. Mhm. Give me 1 second, you guys. I have a private message and I'm just reading it. Okay, so just quick before we get into these NCLEX questions. What is meant? Nurse anticipated. Okay, so nurse anticipates. So there's a question, a private question asked. I'm not going to say the person's name because they asked privately, but I'll explain it publicly because it might help you guys also. So first part of the question is, what does it mean for the nurse to anticipate? Now, that simply means you need to understand management of conditions. Okay. Not only do you need to know management, but you may need to know your signs and symptoms. So, for example, and I'll give you a perfect example. The nurse suspects a client has left-sided heart failure. The nurse would anticipate what signs and symptoms. That is that type of question. Okay. If I suspect the client has this condition, I would anticipate orthopnea. I would anticipate crackles in the lungs. I would anticipate pink, frothy sputum. I would anticipate a cough. Okay. If I anticipate that a client has, or I suspect a client has right-sided heart failure, what would I expect to see? Splenomegaly, I would anticipate splenomegaly, hepatomegaly, jugular vein distension. Okay. That is what that means. Or on the flip side, I have a client that has heart failure, and what medication would I anticipate the doctor ordering? That means what medications, what therapeutic response do we do for heart failure? I would expect the doctor to order digoxin. I would expect or anticipate digoxin. I would anticipate a Lasix diuretic. Okay. I would anticipate using oxygen if needed. That is what that type of question is. So when something is anticipated, that means you expect this type of order to happen. You expect to see this particular type of sign and symptom simply because of what you suspect the client has. Okay. I would anticipate the doctor hanging some IV fluids if I have a dehydrated client. That is what that type of question means. And in the other part of the question, what is meant the nurse is reinforce or enforce a question. So usually reinforcement is possibly done if you have a question on the NCLEX. The nurse just finished teaching. What client statement indicates teaching is not effective? So if you get a question like that, teaching is not effective, that means the client made a statement that is incorrect. The client statement indicates they did not understand teaching because of the statement that they made is not right. So I need to reinforce. Okay. Or if the doctor has said something, the doctor has taught the client something, I need to come behind the doctor. I need to reinforce. Basically, I need to make sure that the client understands what is happening. Okay. So when you see those types of questions, what question indicates teaching was not effective? That's a reinforcement type question. And when you say enforce, that could be teaching also. I need to teach a client about medication XYZ. What do I need to include in teaching? When you get those types of questions, they give you options, and you have to pick the one option that you absolutely have to include in teaching because you are talking about a particular subject. Those are the types of questions that you see on the NCLEX. Okay, I hope that helped answer your question. Okay, perfect. Now let's get into these presentations. Okay, NCLEX questions. Let's go. Question number 1. You guys can type your answer into the chat or you can always unmute. First question, a nurse is teaching a client with hypertension about lifestyle modifications. Which of the following instructions should the nurse include in teaching? Select all that apply. A, limit alcohol. B, increase intake of fatty foods. C, increase sodium intake to 2 grams daily. D, avoid all dairy products. E, reduce stress through relaxation techniques.
A and E.
A and E.
Yes.
A and E. A and E. That voice sounded real familiar. A, A and E. That voice sounded familiar. Correct answer is A and E, awesome, perfect. Limiting alcohol, we've already said. Alcohol causes vasoconstriction. I do not want vasoconstriction. I want vasodilation, so I need to cut out the alcohol. Stress, listen, stress will kill you, okay? Stress is probably one of the number one predisposing factors for cardiovascular disease. Nursing students, those of you getting ready for the NCLEX, I know y'all is stressed at. Trust me, I get it. You got to find a way to relieve that stress and manage it appropriately. Now, fatty foods, of course not. Not only do you have to watch your salt intake, you have to watch your fatty foods intake. Fatty foods could increase your lipids. If I have an increase in lipids, what could I develop? So if my lipids go up, what condition could I develop which could predispose me to hypertension and or heart failure, cardiovascular disease, high cholesterol, hyperlipidemia, exactly. Okay. And then C, why would I listen? 2 grams, 2,000 milligrams. That is a lot of salt, not appropriate. Okay. If anything, you need to limit no more than 1.5 grams of salt daily, even less than that. Basically, we'll tell you a lot of meats, a lot of vegetables, fruit, depending what type of coexisting. So if you have diabetes, you might want to watch your fruit intake. And lastly, avoiding all dairy, not necessary. Okay, you can have dairy. That's not going to directly affect hypertension. Low fat milk, dairy products like yogurt is actually helpful and healthy. Okay, question number 2. The nurse is educating the client about lifestyle changes after experiencing a myocardial infarction. Which statements made by the client indicates the need for further teaching? Select all that apply. So this is a reinforcement question, Sarah. Okay, so you're looking for the statements that means the client did not understand the teaching provided by the nurse. A, I will start a regular exercise program. B, I can continue to smoke as long as I reduce my intake. C, I need to follow a heart healthy diet. D, I should take 2 doses of nitroglycerin when I experience chest pain.
ADF.
I will monitor my blood pressure regularly. F, I should avoid consuming any fatty foods. So, what statements indicate?
BDF.
This client has no idea what I just sat and taught them. I see BD, I see ACEF, BD, BDE. Okay, so some of these we are in agreement on, and then I see Fs, I see Es, but it looks like B and D is the majority of answers. So let's see, the correct answers are B and D. Good job. Okay, so B, continuing to smoke, even cutting down a little bit. No, you need to stop smoking altogether. So if I have a client after I've done all of this teaching, after I just told you smoking causes vasoconstriction, you need to stop. And you say, okay, I'm gonna just cut back. Okay, you didn't understand nothing I just said. That means I need to reinforce teaching. Okay, 2 doses of nitroglycerin, incorrect. The protocol, you take 1 dose, you wait 5 minutes. If you still have angina, which we talked about earlier in the presentation, you take the 2nd dose. Wait 5 minutes. If you still have chest pain, you take a 3rd dose. Okay. If you are still experiencing chest pain after the 3rd dose, that means further assistance, that is a medical emergency, is needed. Now, the options A, C, and E, they were correct. So if your client made those statements, they understood teaching, no need to reinforce. They should
Where's
regularly.
F, Professor? Where's F?
Where did F
Oh,
go?
there is F. I left that out. Oh, let me see. I did leave that out.
Where did F go?
F is also correct.
Yeah.
I'm not sure what happened. It looked like it got caught
I
off.
should avoid all.
I should avoid consuming any fatty foods. That is actually correct.
Correct. Yeah.
It
Okay.
says
Any.
Technically, because of cholesterol, you shouldn't consume any fatty foods. Um, that is actually correct. I don't know why that was left off. Now, I would have to look at that. You could consume in moderation, but I would tell a client to cut fatty foods out because of the risk for high cholesterol. So we tell them typically for a heart healthy diet, we tell you to stick to meat, vegetables, low salt, okay, or low fatty foods, low salt foods, or cut
What
out
about
fatty foods.
what about unsaturated fat?
Say that again. What type of fats?
Unsaturated.
Though, yeah, you do have heart healthy. I would probably, because this was a question that was given to me, I would probably rewrite that and put certain types of fatty foods, like for example, avocados. Avocados are heart
Yes,
healthy.
yes.
Avocados are high in fat, but they are heart healthy. So I would probably revise that. Avoid any fatty foods. It sounds like cutting all out. Possibly no, that is incorrect as well. I will look at that one.
Okay.
I will check that one. Okay.
Thank you.
You're welcome.
Thank you, Professor.
This is why I love the conversation. I'm not sure how F got caught out, and I'm just catching that myself. Thank you guys for catching that. Question number 3. Oh, olive oil is a healthy fat too. So I don't think you should cut out all fatty foods because some are heart healthy fats.
Yeah, the nuts, avocados.
Exactly. Question number 3. A client presents to the emergency department with complaints of syncope, dizziness, retrosternal chest pain radiating to the jaw, despite taking 2 doses of sublingual nitroglycerin. What action should the nurse take next? So this is priority. A, administer another dose of nitroglycerin. B, obtain a blood pressure reading. C, place the client in semi-Fowler's position. D, attach the client to an ECG monitor. So client still having chest pain after 2 doses of nitroglycerin. Your priority action. I see a lot of A's. A's. The correct answer, of course,
B.
Yeah.
Jesus.
B. Now, here's why the answer is B. Now, you guys are not incorrect. This was a priority question. So they're asking what will be the next step. It's not saying, I'm going to go back to the options so you can see what I'm talking about. With this type of question, you got to be careful. It is not saying that the other options are not something that you would not do. Because actually, A, I would do, B, I would do, D, I would do. Okay, raising the head of the bed if the client is experiencing difficulty breathing, I would also do. However, the question is asking, what would you do next? Okay, now, what if the client's pain that they are experiencing is not necessarily determined by them having chest pain? What if it's something that is the reason why they're still having this pain because it's not necessarily related to the fact that I need to take nitroglycerin? So what the nurse is doing is this client has taken 2 doses. They're still experiencing chest pain. Maybe something else is going on. Okay.
Yeah, it makes sense because 2 doses the patient already took, and we need to wait for 5 more minutes. So by that time, we can check the blood pressure.
Exactly. Now, nitroglycerin lowers BP. Okay. And that's why it causes the vasodilation. Your blood pressure should drop. Now, the client is experiencing dizziness. So you guys forgot that part also. Okay.
So can we go back to the question?
Yes, absolutely. Absolutely.
Please?
So the client took the 2 doses already. This is not something that I gave them. Okay. The client came to the ER. They were complaining of dizziness. They were complaining of syncope, fainting, and they're having chest pain. And the client has already taken 2 doses. So technically, their blood pressure should have been lowered. Something else is probably going on with this client. So after the 2 doses, they're still experiencing these signs and symptoms. I need to check the blood pressure to see if something else is going on with this client. Now,
the third dose.
now again,
Yeah, upstairs. Yeah, I was there yesterday. I was on 3rd floor yesterday.
hold on, give me a second.
Third or
I don't
3rd floor.
make sure
Like,
nobody's
Emanuela,
private info.
mute yourself, Emanuela.
sorry.
It's okay. It's okay. Just want to make sure nothing private is said. That's all. Just want to make sure. So everybody who's unmuted, I'm just going to mute you just in case, because I'm not sure who that was. There's a couple of people that was not muted. So again, with this particular question, if the client has taken 2 doses and they are still experiencing dizziness, chest pain, something else might be going on with this client. So you would check the blood pressure first, okay, to see what exactly do I need to do for my next step? If the client is hypotensive, you will need to hold the nitroglycerin, if that makes sense. Syncope and dizziness is a sign of hypotension. When your blood pressure is too low, you feel dizzy, you have fainting spells. So if this client is hypotensive, you would hold the third dose of nitroglycerin. Does that make sense?
Yes,
Semi,
Professor.
again, like I said, placing a client in semi-Fowlers, that might be helpful, but it doesn't address the syncope and it doesn't address the dizziness. That is why that is not relevant as my next priority step. Yes, eventually we will do an EKG or an ECG, but that will come later. I need to first address why this client is dizzy, why this client is experiencing syncope. This is an acute versus chronic question. When it comes to prioritizing nursing actions, one of the frameworks is acute versus chronic. Taking care of the acute issues, the dizziness and the syncope, despite taking 2 doses of nitroglycerin, this client could already be hypotensive. If that is the case, I do not give that 3rd dose. Okay, hopefully that made sense. Also, the client just brought to the ER, an assessment must be done. Absolutely. Who is that? Oh, I know I'm not going to say your name right. But the person who said the comment, assess, that is a nursing process response. You cannot do an intervention until you do an assessment. Absolutely. How do I know I need to give another nitroglycerin tablet? The client said they took the 2 tablets at home. I didn't see them take it. I don't know for sure. I need to assess before I do any intervention. Absolutely. Okay. Good catch. Good catch. Question number 4. When assessing the client for risk factors associated with myocardial infarction, which of the following should the nurse consider a modifiable risk factor? Select all that apply. Age, family history, hypertension, gender, hyperlipidemia.
E and E.
C and E.
Is C and E.
C and E patient. I just saw your comment, Kelsey. Patients already given nitroglycerin. Exactly, you are correct. So C and E, CE, modifiable risk factors. Correct answers, you guys are correct. C and E. Hypertension is something that I can control. Take my medications, lose weight, stop smoking, stop drinking. Okay, hyperlipidemia, absolutely. Take my medication, cut out fatty foods, oily foods. That is what contributes to hyperlipidemia. Okay, age, we said you cannot avoid getting older. Family history, you cannot control what has been passed down through your genetics. And gender, non-modifiable. Okay, now this says males have a higher risk of myocardial infarctions. However, cardiovascular disease overall, women, higher risk factor. So when it comes to like hypertension, coronary artery disease, things like that, we see more women getting treated. For men, heart attacks or myocardial infarctions in particular are more affecting men than women. Okay. And also, as you can see, when women go through menopause, that is something that they need to be on top of, heart health. So yes, modifiable are those things you can change. Non-modifiable, those things you cannot alter. Question number 5. The client presents to the emergency department with retrosternal chest pain and shortness of breath. The ECG monitor is shown in the exhibit. So this picture is the reading that you received when you did an ECG. Which of the following orders should the nurse question? Administer morphine, initiate oxygen therapy, administer heparin, administer amiodarone. Now, I do a presentation where I cover cardiac arrhythmias. However, this is a type of question where you're recognizing this heart rhythm and the doctor gives you an order. And as a protective measure for your client, you're going to question one of these orders, which means if I do this particular order, I can harm my client. Okay, you definitely may see questions like that on the NCLEX. So let me see in the chat. D, I see a lot of D's. The correct answer is D. Yes, good job. I think everybody put D. Good job. So amiodarone, these are one of the medications that we talk about, basic life-saving measures when a client has a life-threatening cardiac arrhythmia. Okay, VTAC, ventricular fibrillation. Typically, when we are managing a myocardial infarction, that is not the first thing that we would do unless the client does develop a life-threatening heart rhythm. Okay, priority is to restore perfusion. Remember what we said: improve cardiac functioning, decrease workload of the heart, get rid of accumulated fluids, okay, and improve perfusion. So those are my immediate goals for managing myocardial infarctions, managing heart failure. I do not go straight to the amiodarone unless the client needs it. Okay. That particular heart rhythm that you saw, that was not a case for amiodarone. When I go over that presentation where I talk about cardiac arrhythmias, we will go more into medications and heart rhythms and things like that. Morphine, yes, it is relieved, used in acute MIs. We talked about morphine decreases the workload of the heart. It calls the client to rest. It manages pain, relaxation. Oxygen, if a client is experiencing respiratory distress, absolutely, you will use oxygen in immediate therapy. Heparin, anticoagulation therapy. Aspirin, that could also been an answer choice as well. Okay, I am looking into the chat. What is the ECG rhythm? Let me see. Please elaborate on the rhythm. Okay, wait, I'm just reading all the catching up in the chat. Just quick question for the people that's putting STEMI. I'm a little unfamiliar with that. Or it's probably something I do know and I'm just not catching on. So for those of you who are putting STEMI, what exactly is that? ST elevation. Okay. I just want to make listen, y'all with these these abbreviations. Okay, yes, that is what that is. Listen now, y'all want to know. Listen, let me tell y'all something. I graduated 20 years ago, okay? 2005.
My
We did not.
God.
Wait a minute now. Okay, yeah, I'm a little in there, but you know, so
You
you
still
guys
look
are
young.
that it's 2005. So STEMI, I have no idea what that is, but now y'all have taught me something. Elevated ST. That is exactly what that is. Let me go back. ST elevation. This does not need amiodarone at all. VFib, VTAC is when I would give amiodarone. This client simply has an elevated ST. That's all that is. Okay. And again, you will not give amiodarone unless there is a life-threatening ECG rhythm detected. This again is just a simply elevation of the ST MI. That was not VTAC. No. 2005. I know, yeah. So I basically just told y'all how old I am. Question number 6. A client is admitted to the unit with heart failure with reduced ejection fraction. Which clinical feature should the nurse anticipate? So for the student who asked me the question about anticipation, this is that type of question. So that means you have a client with heart failure. What do you expect to see? That is all that this question is asking. Select all that apply. Okay. A, nocturnal dyspnea. So difficulty breathing at night. B, orthopnea. C, altered mental status. D, warm extremities. E, urine output. 0.3 mLs per kilo per hour. So that means you will need to have an understanding of what manifestations, what signs and symptoms I would expect to see if I have a client with heart failure. Reduced ejection fraction simply means reduced output of blood from the heart. That's just a fancy way for saying the heart is not pumping a lot of blood like it should. That's all that means. So in the chat, I am seeing
ABC.
A, B, C, E.
ABE.
A, B, E, A, B, C, E, A, B, C. Okay, we seem to be in agreement with at least 2. And then I'm seeing C's and I'm seeing E's. So the correct answers are A, B, C, E. Good job. Good job. A, B, C, E. Now, the only thing that was not typically seen with a client experiencing heart failure is D. I would expect my client to have colder extremities. When you have a reduction of blood flow, okay, your extremities, the temperature is a little cool. Warm extremities indicate good blood flow. Okay, so pale extremities, cool extremities, clammy skin, okay, poor skin turgor. Those are the types of things, poor cap refill. Those are the types of things I would expect to see if I have a client experiencing heart failure. Okay, everything else, because of all of that fluid accumulation, I do expect my client to have nighttime difficulty breathing because you typically lay down when you sleep at night. Okay, that's why we tell people typically to recline when they have heart failure if they're accumulating fluids. Orthopnea, we said difficulty breathing when laying down due to fluid accumulation. Altered mental status. That could be a sign. Now, that is a sign that people don't think about. When you have poor perfusion, meaning a decrease in blood flow to the brain, you definitely could see an altered mental status. Okay. Think about it.
Hypoxia.
Hypoxia, you definitely could see that. So think about it. When you have reduced in blood flow oxygenation, you can see mental health changes. And lastly, having that little output of urine, definitely. How much should people be putting out of an adult? How much urine should an adult be doing per hour? Approximately how much?
30.
About 30 mLs. Exactly. So this client is experiencing something called oligouria, which is usually no output, like, or very, very, very reduced output. Okay. So this is a sign that the kidneys are affected as well when you have poor urinary output. Okay. Good job. Question number 7. A nurse is providing teaching to a client with hypertension who has been prescribed a low sodium diet. Which of the following foods should the client avoid? Select all that apply. Now, this is the type of question when it comes to dietary management. Not only do you need to know the foods the client can have, you need to know client foods that they should avoid. So, B, E, F, fresh fruits, processed meats, whole grain bread, green leafy vegetables, canned soups, and pickles. Check in the chat right quick. B, E, F, B, E. Correct answer, yes, B, E, F. So basically for hypertension, you have to think sodium. Okay, processed foods, a lot of sodium. Deli meats, okay, processed meats like deli meats, you might think, oh, chicken is healthy, not processed deli meats. Okay, pickles, okay, the way that pickles are preserved is a salt solution. So pickles, even though you would think pickles is healthy, not necessarily if you're trying to cut back sodium. And canned soups, worst thing you can have if you're trying to cut salt out. Okay, anything canned, anything. Soups, it could be something that says reduced sodium. If you really read the labels, you'll see the sodium is still elevated, even if it says reduced. Okay, fresh fruits, green leafy, you cannot grow on with green leafy vegetables. As a matter of fact, every type of diet you see when it comes to foods a person can have, green leafy vegetable is somewhere on there. Okay, whole grain breads are healthy. Fresh fruits are naturally low in salt. Fresh fruits. Key term, fresh fruits, okay? Natural, fresh form, not that canned syrup stuff. Okay, good job. Question number 8. A client presents with shortness of breath, productive cough with frothy sputum, and bilateral lower limb swelling. Which of the following actions should the nurse prioritize? A, nebulize with albuterol as prescribed. B, place the client in a semi-Fowler's position. C, start oxygen therapy as prescribed. D, administer intravenous furosemide stat as prescribed. So, priority question. Keep in mind with priority questions,
D.
not
D
saying
for
that all
boy.
of these options you wouldn't do. Okay, it's just asking you what would you do first. So all of these might be something you would do for this client, but what would I do before I do anything else? I see D, I see B.
B for boy.
B for boy, and I see D and B in the chat. Correct answer, B. Now, remember what I said. Sometimes raising the head of the bed is just enough. The client has left-sided heart failure. That's the first thing. So positioning is very important. These clients cannot lay flat. They experience orthopenia when they lay flat due to the fluid accumulation. So sometimes raising the head of the bed is enough to clear difficulty breathing. Now, if I were to raise the head of the bed and my client is still struggling, then I would put oxygen on this client. Okay. Nebulizer with albuterol is not a priority because now that's not, if anybody was thinking A, nobody put A, but if you was considering A, because it said as prescribed, albuterol is typically for bronchodilation. So this client is not experiencing a respiratory issue due to the fact that they have a respiratory condition. Their difficulty breathing is cardiovascular related, fluid accumulation in the lungs due to heart failure. So albuterol would absolutely do nothing to relieve the breathing issues this client has. You would raise the head of the bed first, and if they're still experiencing difficulties, oxygen. Okay. Furosemide is a part of the plan of care. However, it is not the priority action. Okay. So again, with these priority questions, remember, not saying that the other options is not something that you would do. You're just simply answering what would be the first thing that I do before I do anything else. Question number 9, a client with acute decompensated heart failure presents with generalized edema, dyspnea, jugular vein distension. Which medication would the nurse anticipate to be prescribed to address the client's
C.
immediate needs? Immediate, key term.
C.
C.
Well, I didn't even have to read that. Let me see what's in the chat. I see a lot. Oh, well, I see B's and D's. I see C's. So we kind of all over the place with this one. So let's see. Generalized edema, swelling, difficulty breathing, jugular vein distension. Correct answer?
Right side heart
C.
failure.
That's the right-sided. Yeah.
C.
It should be the fluorescent. Yeah.
So the client needs Lasix. Now let's go back. So you see your options. Okay. Now, some people might have thought D because, of course, DIG is a very important drug medication. However, you have to look at the client's symptoms, the edema, the difficulty breathing, the jugular vein distension. This is due to fluid accumulation. Okay. So to address those particular issues, you would give them Lasix. Okay. Furosemide, if that makes sense. I'm going to go to the options to explain the other options. The calcium channel blocker can be used. However, this is not necessarily for this client with this particular issue. Okay, remember contractility is relaxed with a calcium channel blocker, so that will not be the medication of choice. Verapamil, same thing as A. Yes, DIG will probably be a drug we would give. However, this does not provide relief with fluid overload. Remember, DIG just makes your heart contract harder or makes your heart contract more effectively. In order to get rid of the fluid that's causing the edema, the difficulty breathing, the jugular vein distension, only a diuretic would do that. Okay, question number 10. A nurse is assessing a client with chest pain suspected of having a myocardial infarction. Which diagnostic test is the most specific for confirming this condition? Okay. C. Correct answer. Let me see in the chat. I see C's across the board.
Troponin.
Absolutely C. Troponin. Okay. Most appropriate. Now, if some people was thinking EKG can tell us something is going on, but it is not specific for myocardial infarction. Whenever you have a myocardial infarction, there are certain markers that is going to be released from that heart damage. Troponin, if you see troponin, that is a sign that there is some damage to the heart, more specifically caused by a lack of perfusion. Okay. Myoglobulins, that is something you would see with muscle injuries. However, it's not specifically for cardiac. Okay, so you could see A with any type of muscle injuries. It doesn't necessarily have to be the heart. The reason why troponin is the right answer, it stays elevated in the blood for a longer period of time. So if you thought B, you're not necessarily wrong. It's just that that particular value will decrease sooner than later. Troponin stays elevated for a longer period of time. So that is why troponin is a better lab to look for if I'm trying to diagnose an MI. And yes, an electrocardiogram is detecting that there is some decreased perfusion, but if I want to know specifically if my heart muscles have been damaged, I would look for troponin. Okay, good job. Any questions? This was a great presentation. Great, 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 great. I'm seeing my usuals, my regulars, and my new faces. So any questions? So you guys did really, 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 really well. Can I see question 8? What is given to reduce dish toxicity? So it depends. Okay, I'm going to share the presentation again because somebody wanted to see question 8. So someone said, what do we do to dish toxicity? Well, first of all, a lot of times we treat symptoms. So for example, if a client is experiencing respiratory difficulties, we'll give them oxygen. Okay, most times you hold the dose. Okay, that's also something that we do. GLD FIB. There y'all go with these abbreviations. Now I told y'all gonna have to tell me what that stuff means. I graduated 20 years ago, y'all. We was not talking like that. So this is question for Joseph. Let me share. So hopefully, let me get into slideshow view. There we go. Okay, you guys say that again. I wasn't paying attention.
Is the antidote for digoxin toxicity.
Okay. Oh, but listen, y'all have to listen. Y'all got to stop doing these these little I'm gonna stop sharing for a minute before you guys leave. I'm going to put into the chat. Give me 1 second. I'm going to put into the chat tonight's link. So for those of you who have been with me before, you guys know how this works. I'm going to post the link for you to leave your feedback for tonight's webinar. Let me know anything you guys want to see change, anything you want to add. So I'm going back to sharing. So for the person who wanted to see number 8, and I'll show you the answer also, because you said you were still digesting number 8. So that means you probably were still struggling a little bit with the answer. So the question was shortness of breath, productive frothy sputum by lower limb swelling. What would you prioritize? B. Okay, remember with left-sided heart failure, laying the client flat, they're going to experience orthopnea, difficulty breathing when laying flat. Sometimes raising the head of the bed is enough to relieve difficulty breathing. Therefore, the need to provide oxygen might not be necessary. Now, if you were to raise the head of the bed and a client is still experiencing difficulty breathing, then that would be an indication for using oxygen. Remember, a lot of times when you prioritize, unless it is an emergent situation, meaning immediate life or death at that moment, you can try a least restrictive intervention first. Okay, meaning raising the head of the bed is least restrictive. Okay, sometimes that's all you need to do for a lot of clients. They just need to recline and they start breathing very well. Okay, second time, next schedule. Perfect. Okay, so you guys, remember every night there is a webinar. Okay, every night from 7 to 9 Eastern Standard Time and from 9 to 11 Eastern Standard Time. There is a calendar that's going to tell you guys what subject is being taught at that particular time. So 7 days a week, 2 webinars per day you can have. Sometimes there's only 1. But there can be 2, 7 to 9, 9 to 11. It will tell you what specific subject areas is being covered. I typically do Sundays and Wednesdays unless I have something planned, and then I'll change my days up. But Sundays, I typically do mental health, and on Wednesdays, I do adult health topics. Okay, so if you guys are finished and you have no further questions, you guys are definitely free to go. Go back to question. You guys are welcome. Don't forget to click the link. I'm going to post it again just in case for those who may have missed it. Thank you so much for the nice words. So I see a question asking me the first 10 questions, not the hard ones. So here's the thing about the NCLEX, okay, when it comes to questions. Now, remember, the NCLEX is self-adaptive, which means your questions will determine how you answer the previous questions, okay? if you are steadily answering questions correctly, they get harder and harder. If you by chance answer a question incorrectly, the next question is easier than the question that you just answered. Once you are steadily answering questions, then the computer shuts off. Now, if the computer keeps going, that means that the computer is giving you an opportunity to start answering questions consistently correct at a specific difficulty level. Remember, you do not have to be a super nurse to pass the NCLEX. You don't have to know everything. You just have to know the minimum to take care of a patient effectively and safely. Okay, so typically these are questions just to give you guys an idea of the type of questions that you would see that would coincide with. A lot of times the difficult questions are like the select all that applies, those alternative style questions. Those would be the more difficult. So select all that apply, drag and drops, what else? Fill in the blanks. Usually those are your high acuity type questions. Lasix instead of DIG. You guys are welcome. You guys are welcome. And again, for the recording, I'm going to try to find that question. I think it was this one. And for the previous recordings, remember, there's a link that says previous webinars. So once the webinars are uploaded, you would click on that link and you can download the webinar, okay, in the presentation. So I think this was the question that you was asking me about. Why was it Lasix instead of DID? Because of the client's symptoms was related to fluid overload. Okay, and the DID would probably be something that you would give, but to specifically address these signs and symptoms, you would give the client Lasix. Okay, let me see. No problem. You're welcome, Ms. Cox. So let me see. Thank you, Ms. Rizza. I hope to see you guys again, Sundays and Wednesdays, but any day of the week. Again, check the tutoring schedule, and you guys will see the topics that will be upcoming and covered. You guys are so welcome. So if you guys have no more questions, okay, again, make sure you click on that link. You're welcome. Anything you guys want to, see more of, you have suggestions, that would be the time to put those in your in the link. Okay. Naxlex, the administrators, they do listen to students. A lot of suggestions students have been making, they are implementing. So you're not just doing it just to do it. They are truly, truly, truly taking your suggestions into consideration and is improving the services and the products for students. Will there be a tutoring schedule? So that is something that students have been talking about. Okay, so that is something that you can definitely suggest that you would like to see. As of now, there's not one-on-one tutoring, if that's what you're asking. For right now, we just do the webinars in this type of format. But this is technically like tutoring, if you want to look at it that way. But as far as like individual specialized, that is not something that is offered just yet, but you can always make that suggestion. Thank you so much. Y'all so sweet. You're welcome. Okay, so again, you can click on tutor sessions. That link will tell you what all webinars are you're going to have for the upcoming days. Okay, if I'm not mistaken, you can see as far as August, maybe, depending on how much has been scheduled. You can look that far up ahead. You guys are so welcome. So if there's no more questions regarding the presentation, I will conclude and I will see you guys hopefully on Sunday. We'll be covering mental health topics. You guys have a wonderful night. Thank you guys for joining. Newcomers.
Professor.
Thank you so much. You are a blessing. You are a blessing for real.
Thank you. Thank you.
Good morning. Thank you.
Bye, guys. See you guys.
Thank
Bye,
you, Prof. God
Prof.
bless you.
Bye. Have a great day.
And you too.
Sunday,
Bye.
9 p.m. for tabs. 9 p.m. I'm usually 9 to 11. Okay.
Oh,
Bye,
for
you
today.
guys.
Is that for Sunday?
Yes, Sunday. But like I said, you go into the tutoring sessions, you'll see the calendar. It'll
It's on
tell you the
Facebook, right?
topic and it'll tell you the professor.
Is that on the Facebook, ma'am? I'm sorry.
I don't think it's on, I don't know if it's on the Facebook, it's on the Naxlex website.
Oh, okay. Okay.
That link,
Okay.
yeah, that tells you
Mhm.
what webinars are upcoming.
Gotcha. Thank you,
You're
Professor.
welcome.
Appreciate it.
You're welcome. See you guys hopefully on Sunday.
Okay, bye bye.
Bye.